We are switching gears. We're going to talk about everyone's favorite topic, favorite exam, the neuro exam. We love this. We love it when a patient comes in with dizziness and back pain. Okay, I'm being a little facetious, right? I mean, I think this is the exam that we're all like, ugh. Is someone else going to pick up that patient? I hope someone else picks up that patient and maybe I won't have to go and do that exam. It's tedious. It's a little bit scary. There's so many different things it could be. Do they have a really life-threatening emergent complaint? Or is this just like a chronic, a chronic back pain problem or a rotator cuff injury? It really runs the gamut. Now, when we talk about a rapid neuro exam in the emergency department, maybe the first thing that comes to mind is that very directed exam we do to figure out if a patient is having a stroke, and specifically a large vessel occlusion. Like, is this person in the window for thrombolytics? Can they get a procedure? And that is a very rapid exam. I would argue that that is just a really rapid neuro exam. And we are going to talk about that. But every neuro exam we do in the ER is a rapid neuro exam. We don't have the time to be doing the kinds of exams that we learned on a neurology rotation. We're not pulling out all of our tuning forks and smell, coffee beans to test cranial nerve 1. Like, we don't have the time for that. Just like we don't write an H&P like a hospitalist or an internal medicine doctor. Our exams are focused. They're rapid, they're focused, they need to be effective and efficient. And that's really what we're going to talk about today. At the end of the day, the question is the same. Is this a brain problem? For example, someone can't move their arm. Is it a brain problem? Are they having a stroke? Or do they really just have a rotator cuff injury? Is this more of a musculoskeletal issue? There's a large differential. So we need to figure out, is this a brain problem? And is this an emergency? Do I need to activate the ELVO team, the stroke team, transfer this patient, get imaging really quickly? Those are the big things we're trying to answer. So these are the main parts of the neuro exam. And it is very important that you all have your own neuro exam that you do the exact same way every time. Now, you can omit certain parts. You can and you should tailor your exam based on the patient's complaints, right? Like, you're going to dive into particular sections a little bit more, back off of some sections a little bit more. But for the most part, you need to have a structure that you're working through where you're hitting each component of the neuro exam, going through it the same way for every patient. And practicing it over and over again is the way to get there. A lot of the neuro exam can be done just by taking that initial H&P, just by talking to the patient. When you first sit down and you say, what brought you to the emergency department today? So much of that neuro exam can be assessed in those first few minutes, just in the H&P. Now, let's talk briefly about stroke, because there's no way to talk about the rapid neuro exam without hitting stroke. We have to do it. And we have to talk specifically about those large vessel occlusions. Again, I would argue that most of us are pretty good at this. You have to be, right? When we're thinking this person may be a candidate for thrombolytics, we need to get them imaging, we need to transfer them, we need to call our stroke colleagues, you've got to be pretty quick. And a lot of times it's profound. You can tell right away that this person is not talking back to you, they have profound deficits, it's usually pretty profound. It's not usually very subtle, but there are different approaches we can take to get that rapid neuro exam done, and I'm gonna tell you my approach. So we have probably all heard about the VAN. Have you heard of the VAN assessment? This is the pre-hospital assessment for stroke. It is really pretty good. It's been shown to be very good. And so that's what I fall back on when that patient rolls in and I have 2 minutes to figure out if this person is within the window, if I think they're having an ELVO, and I need to activate the stroke team, or if, in some settings, transfer this patient. So let's walk through that. VAN. The first one is vision. We're going to assess their vision, and you're going to look at the patient and try and do visual fields. Now, there's two different ways you can do this, confrontational visual fields. One is you can look for visual neglect. And this is present in like 70% of LVOs. So this works pretty well. When you're doing visual neglect, you come face to face with the patient. You want to be at their level. If they're in the gurney, you're going to come down to their level. If they're in a chair, you're going to sit across from them. So you really want to be face to face with the patient. And you don't have to cover both eyes. You're really just evaluating this big visual field and this big visual field, because visual neglect is really looking for that whole visual field is out. It's like a homonymous hemianopsia where the whole side of the visual field is out. And so you can really just look at the patient and you can look at my nose, focus on my nose, make sure you're focusing on my nose. How many fingers am I holding up? How many fingers am I holding up? And if they can't engage with either of those, then that visual field is out, and that is very concerning. So that is visual neglect. The other way that you can do confrontational visual fields, which is like a little bit more detailed, again, always at the same level as the patient, sitting, however you can be face to face. Look at my nose. That's really important. You need to make sure that they're focusing on your nose and not focusing on your fingers. And you have them cover one eye. So if I'm covering this side, the person looking at me is going to cover their other eye, right? On this side, it's going to mirror my hand, okay? We're mirroring each other. And then I hold up fingers in this quadrant and in this quadrant while they're looking at my nose. I'm testing this field, switch hands, they switch hands too, cover it for them, this field, this field. So I'm using myself as a guide, right? If I can't see it in my own visual field, they can't see it either. That's why I'm covering my own. So you use yourself as the guide to figure out the visual fields, and then you get all four quadrants. So that's the quick way to do all four quadrants. But when you're evaluating for an LVO, you can kind of do a quick and dirty, look at me, look at my nose, how many fingers am I holding up on this side and this side, and that quickly evaluates for visual neglect. Okay, so that is vision. The V. A, aphasia. So there's expressive aphasia and there's receptive aphasia. And we're going to evaluate for this by basically asking the patient to name two objects. Hold up a pen. What is this? Point to your watch. What is this? Okay. So can they express what they are seeing? And receptive aphasia, you're going to ask them to do commands without giving them visual cues. So without saying, raise your right hand, I'm not actually showing them. It's like, please raise your right hand, or stick your tongue out, or give me a thumbs up on your left hand, without giving them any visual cues. Because you're trying to figure out, can they understand what I'm saying? Trying to follow commands. And then one extra little piece to assess their language is just a short sentence. Please repeat after me. I'm fine today. Just to hear how they're talking. Because one thing that's often confused with aphasia is dysarthria. Dysarthria is motor weakness. They're not having trouble understanding you. They're not having trouble producing speech. They're having trouble with their muscles. And so when you actually have them say a phrase, you can better assess, is this truly dysarthria or is this aphasia? We're looking for aphasia. Okay, we talked about vision. We talked about aphasia. N, neglect. This one is usually pretty obvious. Is the patient engaging with both sides of the bed? Usually we approach patients from one side. They're, hopefully looking and talking to us. What you can do is you can actually just go on the other side of the bed and make sure that they're looking and talking to you on the other side. Even easier than that, and what I usually do is have the nurse, who's usually starting an IV on that side, because I don't want to be in their way. They're usually starting an IV over there. Just try and talk to the patient, engage with the patient. Are they moving their arm when they get that IV? Are they withdrawing? Are they doing anything? So whoever's standing on that side, getting the blood pressure or the IV, whoever's on the other side of the bed, I just try and get them to kind of get the patient's attention. Neglect is pretty profound. You can tell that the patient is not looking over there, not moving that side, not paying attention to that side. So those are three components. There's one more really important component. That is upper extremity weakness. And we assess for that by doing the pronator drift. It's very sensitive and specific. Pronator drift. Remember, so many patients, when you say, hold your arms up to the sky for me, they first go like this. Because it's actually a lot easier to pronate than it is to supinate. This requires more strength to keep your arms up to the sky. So you remind them up to the sky, and if there's any subtle pronation, it does not have to be an actual drift. Literally just the pronation movement, because again, this is a stronger muscle. It's harder to do this. This is weaker. So the tiniest little pronation, that means they have pronator drift. Doesn't have to be a full drop of the arm. So if they have upper extremity weakness and any one of those other things, a vision problem, aphasia, or neglect, they only need one of them, plus upper extremity weakness, that test is positive. We're saying this person needs to be tested for an LVO, they need to be transferred, they need to get imaging. Are they in the window? Okay, so that is our super duper rapid stroke test. Super duper rapid. But we've got to talk about other things that are harder to diagnose, I would argue. These subtle findings, patients who come in with some dizziness, patients who come in with eye complaints, patients come in with just a pure sensory deficit. Those are so challenging. And I think that's when our neuro exam, we really have to rely on a good neuro exam, and we have to have a good approach for what we're doing. I think a lot of us may have the motions down for doing the neuro exam, but we don't always know what we're looking for. Sometimes we forget about our differentials, or you forget what that test is actually testing. What are the components of this test actually testing? All those different cranial nerves, all the different motor testing. I just talked about pronator drift. What are we actually testing there? When we talk about Romberg, a lot of people get confused about that. That is proprioception. Right? So we forget, sometimes we get confused about what it is we're looking for, and we need to have a framework, which is why I've just put up a few reminders of other things that we need to be thinking about. Other things that are tricky. I think the eye complaints are particularly challenging. A couple words on this. Remember, internuclear ophthalmoplegia, should be thinking about MS. And what is that? What is INO? It is usually a lesion in the MLF. Thanks, Jessie, that's really helpful. So what it means is the median longitudinal fasciculus is not working properly. For example, here are my eyes, here are the eyes. If I have an INO on the left side, I cannot adduct that eye. So here's my nose. I can't adduct the eye. My lesion's on the left. I ask me to look right. My right eye looks right. My left eye just stays looking forward. It can't adduct. That is an INO. That's concerning for MS. So some of these, you see them and you should it's kind of a bing bang. I see this, I'm thinking this. Binocular diplopia, double vision. So if a person covers their eye and they have double vision just in one eye, not always, but that is more suggestive of an eye problem. If they have double vision with both of their eyes open, more suggestive of a central problem, a brain problem. Just a few things to think about. Afferent pupillary defect. We're thinking about cranial nerves, vision loss, stroke of the eye, right? Arteries, thinking about retinal arteries, ophthalmic arteries. So very painless monocular vision loss. Sort of classic teaching is that's a stroke of the eye. We work it up like a stroke. Same way. This is just as serious as a stroke. And then cranial nerve deficits. In general, cranial nerve deficits come in groups when it's a central process, when it's a stroke process. If it's just a single cranial nerve, it's not always, but usually peripheral. Talk more about that. All right, what are some other things? Again, it can be tricky. Patients who come in with dizziness, they come in with back pain, they come in with sensory. We need to have a broad differential, and we need to be thinking outside of the box. It's not just stroke. There's a lot of other things that we need to know how to diagnose. Could this potentially be MS, multiple sclerosis? Do they have a spinal cord lesion? So when the person comes in with back pain, we need to be able to assess, is this a spinal cord issue, which is of course an emergency. ALS, we're not always thinking about ALS, but we have the capability to assess for upper motor neuron signs and lower motor neuron signs. And in ALS, the patient has both. It's insidious, it's progressive. myasthenia gravis, radiculopathy, neuropathy. Is this a stocking and glove distribution? Or do they have like a dermatome, an entire dermatome, a radiculopathy that's affected? Time matters. And it doesn't just matter for stroke. Like, yes, it absolutely does when we're trying to decide if this person is a thrombolytic candidate, if they're a candidate to go for thrombectomy. Remember, the window is 4.5 hours to get lytics if they're a candidate for that. And at our shop, 24 hours for thrombectomy. So time matters for stroke, but it matters for a lot of other things too. Spinal cord. A cord compression, that's a true emergency. The longer that a patient is going on with cord compression and pressing on the cord, that's their outcome is much worse. They're much less likely to regain function. So spinal cord, things like infection, spinal epidural abscess. That's also timely. That's something we need to diagnose very quickly. Those patients are high risk for adverse events. There's a lot of things. Vision loss, as I just talked about. Monocular vision loss, those patients, that's an emergency. So there's a lot of things that are really timely when it comes to the neuro exam. Walk them, talk them, look them in the eyes. These are arguably the most important components of your neuro exam. So like if you really don't get everything done, you have to walk the patient. You have to walk the patient. And in the most simple terms, if that patient can't walk, they cannot go home. So you have to walk the patient, not only to help you figure out what's going on. You want to look at that gait. You want to see, do they have, paralysis? Do they have sort of an antalgic gait? Is it pain? What's going on with their gait? But can they actually walk? Because if they can't go home. You want to talk them. We talked about aphasia. We talked about dysarthria. That's pretty important. And you can assess so much of that in the initial H&P. Just by getting your H&P in the first few minutes and looking the patient in the eye. You're doing a little bit of a cranial nerve exam just by having them look you in the eye and talk to you and see if they're tracking, do they have neglect? All right, so we already talked about this, the parts of the neuro exam. Let's move through it. This is my rapid neuro exam. I'm going to start with mental status. Again, so much of this is done in my initial H&P just by talking to the patient. The general level of alertness, the ability to interact are the best overall measure of mental status. A couple things to remember. Awake is not the same as alert. Alert means, is the patient responding appropriately? Can they actually respond appropriately to you? Awake, a patient could be in a persistent vegetative state and be awake, but they are not alert. They are not able to respond appropriately to you. So there's different categories that we're paying attention to when it comes to mental status. And if any of these are affected, you can go on and do more of a mental status exam. You can look for encephalopathy. You can do a mini mental status exam. I would argue we're not really diagnosing dementia in the emergency department. That is for the neurologists and the psychiatrists. But we can get a sense, is this delirium? That is something we should diagnose in the emergency department. Is this delirium? What's the time of onset? Is it acute? Is this encephalopathy? Like, do they actually have a deficit? Or are they just encephalopathic? So that's the kind of stuff we're assessing with our mental status exam. That's first. Next, I'm moving down, I'm doing my cranial nerve exam. And I'm starting with the eyes. So much can be gained by assessing the eyes. Now, here's one thing to remember. Cranial nerve 2, the optic nerve, exits from the cerebrum. All the other cranial nerves, 3 through 12, they exit through the brainstem. And that's why, the brainstem's a really busy structure. And so if there's a problem with the brainstem, patients usually have more than one cranial nerve involved. That's the thing to remember. It's rare to have just an isolated cranial nerve palsy. That's why I was saying it's usually more peripheral. Not always, but usually it points to that. When we are assessing our cranial nerves with the eyes, of course, we're going to look at the patient. We're going to do those visual fields that I talked about. Make sure you do your visual fields. Pupillary exam, looking for an afferent pupillary defect, making sure doing your swinging flashlight test. Because remember, cranial nerve 2, the afferent limb comes from cranial nerve 2. So when I shine the light into the eye, that's the receptive part. And I shining the light into the eye, their pupil should constrict. The other pupil, the consensual side, is the efferent limb. That's cranial nerve 3. So a lot can be gained just by doing that swinging flashlight test. Is it a cranial nerve 2 problem? Cranial nerve 3 problem? And then you're going to trace the H. You guys know. So having the patient look up, down, across, up, down, tracing the H, you're testing those extraocular movements. Can they adduct the eye? Can they move up? Can they look down? That points to different cranial nerves. So you're doing a really good eye exam. Visual fields, pupils, movement, all of that matters. If the patient does not have dysphagia, dysarthria, trouble swallowing, you really don't need to move on to cranial nerves 9 through 12, right? That's more specific. This is where you tailor your exam. Cranial nerve 5, you're testing the sensation of the face. Cranial nerve 7, you're having them do all that funny stuff. Smile, lift up your eyebrows. Done so quickly, right there, boom. I do my eye exam, I test the face, I have them smile, show me a big smile, lift up your eyes. Because remember, cranial nerve 7 is also responsible for keeping your eye open. So when they have that droopy lid, that's a cranial nerve 7 problem, the ptosis. And we all know that, right? Because Bell's palsy, right? We know it's cranial nerve 7 problem. We know what Bell palsy looks like. So if they have a swallowing problem, that's cranial nerves like 9 through 12. I'm going to go on and test that, dysphagia, dysarthria. But if not, I'm skipping those. I don't need to do that on every patient. Now we're moving to motor, okay, kind of coming down. Mental status, cranial nerves. Let's get into motor. It's really important to have a way to grade the motor exam. This is the best way. So it's 0 through 5. I would say functional motor testing is actually better than sort of push-pull testing. So if the patient's sitting, can you stand up out of a chair unaided? Can you walk independently? That is a great test of their motor exam right there. Like literally just having the patient walk, can you walk on your own, tells you a lot about their strength. If you need to, you can, of course, do push and pull testing, upper and lower motor, push up against my hand with the foot. But sometimes I'll just have the patient stand up, walk, do a few things with their arms. I always do pronator drift. That's, as I said, a really nice exam for motor. Always do pronator drift. And there's another part of the motor exam, which is looking. Do they have good strength? Do they have any wasting, muscle wasting? Look for range of motion, because that can also point in a certain direction. Maybe this is a rotator cuff injury. Maybe this isn't a brain problem. Pronator drift, love it. Sensory, this is purely subjective, and I would argue, one of the more frustrating parts of the neuro exam. I think it's hard. Sometimes we're like, really though? Like, is it really numb? Can you really not feel this? Come on. You have to trust the patient. As frustrating as it may be, sort of as skeptical as we may be, you've got to trust the patient. That's the number one thing. And you should be consistent in your testing. It's important to eliminate vision, because remember, vision gives us a lot of clues about what's going on. So you have the patient close their eyes, and then you trust the patient. You're looking for things like, is this a sensory stroke? Is this a thalamic stroke? Do they have a dermatomal level? Is this a spinal cord issue? Like across their back, find that level. Is this a radiculopathy, as we talked about, one specific dermatome? Is this stocking and glove? What are we assessing with our sensory exam? So those are different things you're trying to figure out. Is this a spinal cord issue? Is this a peripheral nerve? Is this a pure sensory stroke, like a thalamic stroke? Dermatomes, there we go. Reference them. You got to look them up. Cerebellum. The next thing I'm testing, so I've done motor, I've done sensory, I'm testing their coordination. Essentially their cerebellum, but really it's coordination. And you can do this in different ways. Finger to nose is pretty much the same as heel to shin. So I'm not always doing heel to shin. Sometimes I'm doing finger to nose. Patty cake, dysdiadokinesia. If they can't do patty cake, that's what we call that. And you're just testing their coordination. Really important. Romberg. So many people think this is a cerebellum exam. It's not. Romberg is not. This is a problem with your peripheral nerves or your posterior columns. This is a problem with proprioception. And when you do Romberg, you do it with the eyes open and with the eyes closed. A lot of times patients are okay doing it with their eyes open because they have those visual cues. Even if they have peripheral neuropathy, they have visual cues. And as soon as they close their eyes, they really don't know where they are in space. It's a proprioception problem. And that's when they get kind of, they can't keep their balance. So that's what Romberg is. If a patient is actually having a stroke and they have truncal ataxia and they have a cerebellar vermis problem, they're going to have that with their eyes open or closed. And then the last thing, gait. You got to walk the patient. You got to walk the patient. You got to walk the patient. It's a pain. It's a hassle. It's hard. We don't always have the right spot, but you just can tell so much from walking the patient. This is the part of the exam you cannot skip. Reflexes. We're not always doing reflexes, but it is part of the full exam and it can be done really quickly. And if there's any concern for some sort of ascending motor paralysis, anyone who works in an area where Lyme is endemic, you can get that sort of paralysis. You can have lots of different upper motor neurons and lower motor neurons can be assessed using reflexes, right? Do they have increased spasticity? So it's good to have in your back pocket and at least testing these three. You're going to test the biceps, the patella, and the ankle. You don't have to do like a full reflex exam, but those three are quick, they're easy. You can do them very quickly at the bedside. So biceps, and it localizes, right? Biceps C6, patella L4, ankle S2. Do they have a foot drop? Okay. The last part of your reflex exam is looking for clonus, because this can tie you in to a sympathomimetic, some kind of toxidrome, right? Do they have some kind of toxidrome going on? Do they have serotonin syndrome? Do they have sustained clonus? People who have a severe brain injury may have sustained clonus. So something to always check on your patients as part of your complete exam if signs are pointing that direction. So quick review. Talk to the patient. So much is gained in that initial H&P just by assessing their mental status. Are they looking at you? How's their language? How's their speech? Actually, here's a little story. I had a patient the other day who was Spanish speaking. It required an interpreter, and he had a beautiful neuro exam. His brother had brought him in because he said his brother had a headache. And in speaking to both of them, maybe he hadn't been exactly himself for the past few days. When you first talked to this gentleman, he seemed like he was holding up the conversation just fine. He could tell you. I said, "Why are you here?" "Yeah, I have a headache." "Okay." "You do your neuro exam, no motor deficits. He can walk. He's interacting with me." I said, "Who's this guy here beside you?" "My friend." I said, "That's your friend?" He said, "Yeah, it's my friend." And I said, "This is your brother." And I asked the brother, would he normally know that he's your brother? He said, yeah, no, this is what I'm saying. He's just a little bit off. All of this was just by getting a history. His exam was really normal. He had no other signs, but in kind of diving a little bit deeper, you could tell he was just a little bit off. Okay, this is his friend. It's actually his brother. He knew the year, but he didn't really know exactly what day it was. Now, granted, we don't always in the ER either. Sometimes it's hard to be in ANO times 3, but he was just a little bit off. And just by doing an H&P, we could assess that. Ultimately got a head CT, he had hydrocephalus. He had obstructive hydrocephalus. He didn't have any of the other signs. He wasn't wet and he wasn't wobbly, but he was a little wacky. So that's just to say the H&P is so important and you have to trust your exam. And you have to trust the patient, especially when it comes to things like sensory. Do your cranial nerve exam. It's quick. Just keep practicing it. The more you practice it, the quicker you'll get. Motor, sensation. You're going to do your cerebellar tests. You're going to plus minus your reflexes, depending on the patient's complaints. Always walk the patient. Always walk the patient. Neuro is anatomy. So review it. Review the chief complaints. Review the things we should be thinking about. Review the anatomy. It is complicated, but the more you read about it, the more you look at it, the better it will become, the easier it will become. Take home points. Do it right. I wouldn't say don't do it at all. You got to do it, but do it right. You don't always have to do a full exam. Have that full exam in your back pocket, but tailor it to your needs. And if you can't remember the anatomy, because it is complicated, you can always look it up. When in doubt, describe what you observe. So if you're not totally sure, someone seems just a little bit off, that's what you write. You describe what you observe. Practice makes perfect. Thanks.